Hello, my name is Anjum Khurshid and I'm very pleased to join you virtually at this Global Public Health Conference, and I apologize for not being there in person, but because of some travel challenges I couldn't be there, so I'm sorry, but I'm also very glad to have the opportunity to share with you some of the experiences of implementing community-focused work in the United States with all the colleagues, and I hope that we can, in the future, think of more collaborations and also have a chance to meet in person. So, without further ado, I would share my slides to start describing some of the work that we have done. And the topic of my discussion is empowering communities to share, link, and analyze medical and social service data for collective impact, as I believe that healthcare is mainly a data business and information business, because we collect a lot of information, we share a lot of information, and we need a lot of information to make good decisions to improve the population of our communities. And therefore, having the right infrastructure and right governance at a community level is extremely important for success of various interventions in public health. So I'm an associate professor in population medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. I also am the director of the Center for AI and Biomedical Informatics that we have recently launched. So the outline of my presentation is mainly to talk about data challenges for community empowerment, data fragmentation problems in healthcare particularly, proposed solutions for social and health information use, and then we'll go through an actual implementation and various aspects of that in the real world, and then assessment of these social needs and collective action based on those needs, and some final thoughts. So, health and social services in a community should be focused around a household or an individual. And as you look at this, a household or an individual or a family engages in community support through multiple entry points. It could be through community-based organizations, it could be through health community clinics, schools, or other entities. And in order to coordinate care and support, we need to ensure that social and health needs across the community are coordinated, that we close the loop with streamlined social service referrals and follow-up processes, which means that the information is shared among all the people who are taking care of that family or an individual, and that we develop community solutions through collective action. So one of the things that is important and drives this thinking is the fact that over the last many years there's increasing evidence to support the fact that the factors that impact health of communities are broader than what direct medical services would include. And if you break them up, as you see in this diagram, that you will realize that there are health behaviors, there are social and economic factors, the physical environment that determine more than 80% of outcomes in communities. And clinical care, which includes our hospitals, clinics, physicians, nurses, etc., play an important part, but a smaller part in that. So we spend a lot of money and a lot of effort in trying to understand clinical care and delivery of healthcare services, but we do not necessarily link it to all other factors that also affect the outcomes in individuals and health communities. And that's kind of the work that has to happen at a community level, and where social services and healthcare services have to be combined. And the result of this, best example of this is the United States healthcare, which, as many of you know, spends the largest amount of money on health, which is almost $4.5 trillion. And yet the outcomes are not as one would expect with that amount of money. And so this refers to a book that was published a few years ago called Healthcare Paradox by Elizabeth Bradley, And then it compared total expenditure of both healthcare and social care across some of the Western countries, and showed, as you see, that United States lies in the middle. For every dollar that we spend, which is in green, on healthcare or on social care, we spend $2 on healthcare. So we spend much more on that 20% that we saw in the previous diagram on direct healthcare services and hospitals, clinics, etc., versus social care, which can actually determine some of the social behaviors and other environmental and factors that affect health. And some of the countries that spend actually twice as much on social care than on healthcare have better outcomes than what we see in the United States. So that's kind of the paradox of spending more on healthcare directly and yet having less health outcomes in the community. So as a result, the challenge that we have in the United States and many other communities also is how to connect these two pieces, because they are both essential. It is not one versus the other, but they have to be all coordinated, and they have to be coordinated around the individual or a family rather than at the organization level. So starting with the WHO definition of health, which defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, as most of you understand, then we are thinking of a more holistic wellness approach to health policy and health interventions in public health than just a very treatment-oriented fixing disease thinking of health. So that's kind of the overall idea. But data plays an important role in ensuring that we can provide better services, that we can evaluate those services, and we can improve them as part of a learning health system. But the challenges in communities around data are based on the fact that data are collected in very fragmented way, in very siloed fashion. So data are in different organizational databases. They don't necessarily talk to each other, and they can't share their data easily, especially when you think of sensitive data that requires privacy and confidentiality and consent. This becomes a big challenge. As a result, it's harder to get data for making collective action. Similarly, the complexity of the data is there as well, because the terminologies are different that are used in social care services versus what are used in healthcare in terms of who is delivering it, what type of services are being delivered, and all these things matter. And then finally, there are also rules and regulations and processes to access that data if you want to really collect that data to try to understand what is going on in a community, in a population, to be able to assess programs, analyze programs, and design programs. So these are very specific data challenges that we see across the globe, but especially we see in the United States, because we have digitized our healthcare services tremendously, but the social services are still catching up. So the solution that we proposed in terms of how do we address this is to really think of a digital platform that can facilitate this data sharing across sectors, across organizations, and that can integrate clinical and social data into user-friendly longitudinal records around individuals, so that we can really see an individual holistically rather than in piecemeal based on organizational data silos. And in order to make this work, you have to make this available in the workflow of those who are using these systems and who are providing this care directly. In many cases, in the United States at least, it will be electronic health records that are used to deliver services and monitor them. And the digital platform then can allow those data to be easy to read, easy to access, actionable. It can facilitate patient care and coordination for individuals, and it can help provide increased insights into what trends are happening in the community, what service gaps are there, and what possible solutions can happen. So we looked at 3 different sources of data: the social needs assessment data, which is usually an intake form where people come in to a community organization or a clinic. They are asked questions about their situation, a socioeconomic situation. Are they employed? Do they have housing? Do they have access to food? And then there is a social service referral. Depending on their needs, they are referred to an entity so that a government program or a local program that can help them. And finally, it is connected to clinical data, which in this case, we were looking at Health Information Exchange, which is a centralized organization that collects data. Combining these three sources of data together will give us an idea of what is going on in the community for individuals who need social services, who have clinical needs as well, and then how can we provide for that as a community. So we had a three-tiered strategy in building a platform like this. There is the major part, or the first part, is community engagement. So we really engage the community to understand their needs and what their preferences are. We then use a user-centered or human-centered design, using Human Information Interaction Lab and using some generative research to develop these the platform ideas. And then final part is technical solution, which is how do we use informatics and technology. There is a health information exchange platform that connects the various electronic health records. There are application programming interfaces that allow these different systems to talk to each other. And then we link them through a privacy preserving record linkage system, so which preserves privacy and protects privacy of individuals. So this is how we decide to build a platform for a community to address its data needs for collective action. And the community engagement, and this program happened during some of the COVID years as well, so a lot of these were virtual meetings, but really had a representation from across the community from a particular strategy called a community engagement studio, where individuals from the community are considered experts, and they work with the researchers to actually answer questions. They are not subjects of a study, but they are really co-researchers in this case, and they share their experiences. As a result of engaging them into this, they also feel appreciated and respected in terms of their input. And they also understand better the purpose of the research that is being done. And so we have published some of these results. You can see the references there. The Community Engagement Studio basically relies on different meetings, which are not exactly focus groups, but really discussions, as I mentioned, with community experts on experiences of their health and healthcare, on community readiness for innovation and technology, for design preferences, when we go into more details about what they would like to see in a platform that they want to be used for their information, in adoption of this innovation, and then sustainability of this innovation. The human-centered design process then basically looks at other scenarios, other apps. It understands the designing of these in a technical environment, and then does an iterative process of working with these community experts in terms of presenting to them, based on their input, what kind of platform should work, and then translating these inputs into design, testing it with usability testing of how easy it is to be used by individuals, and using some participants to test this. And then based on those usability results that you see here, it looks at doing different tasks on that platform. So as they navigate this platform as a user, and this could be a user as a community health worker or a physician, or it could be a user as a patient who is using this platform. And in the technical design, which I won't go into too many details of that, but basically being able to collect data from multiple places, which is what the Health Information Exchange on your left side looks like. It collects data from multiple places without each one of them connecting to all the others, but they all connect bidirectionally to a central platform, and hence there's a network. It's almost like a wireless telephone system. And then there's the privacy record linkage through a data set, which then allows for individuals as well as organizations that are providing services to connect with that data. And as a result of this, we developed an application that can be used on a mobile by individuals. It's called FIRED. The first 4 letters are an acronym for an interoperability standard called Fast Healthcare Interoperability Resources, which allows for clinical data to be shared much more easily. And as you see, these are screenshots that have been developed in consultation with the community or in partnership with the community. So the colors, what kind of images they want to see, and the first screen they want to see their medications and other kinds of things, and then their detailed labs and other notifications. It also allows for identifying your medical records, your medications very quickly and navigating between them, so a patient can or a family can use this effectively to get data from multiple data sources. And it can also allow other applications to work on this, so you don't have to download different applications, but a single application can work in this way. And we then expanded that to also include social services. So now you can actually fill out the social assessment forms on this and also track any referrals that have been made for social services. At the organizational level, because we are talking of hospitals, clinics, emergency medical services, pharmacies, they have to be connected again to these social service data, and this happens through the health information exchange, as I've already mentioned, and that is connected to a platform that connects community organizations and captures all the social services and social needs assessments. And this is a social and health information platform that tracks all these things and links them together. Again, this has been published in peer review publications in Applied Clinical Informatics, and the reference is there for more details. Once this has been implemented, you can see that on a screen in an electronic health record now, when a patient's records are opened, relevant information about their food or housing or transportation needs, etc., are also shown. And then in designing this with the community health workers, who are the social workers that also interact with individuals, you can see there are also different languages it can be translated into, and then working with the staff in the clinics to actually understand their workflow and making their task easy as they try to interact with patients and help them through both clinical and social conditions. We implemented it especially on a food insecurity referral system, where patients who had any food insecurity issues and were seen in a clinic could be referred to a community food bank, where the food bank then receives these electronically and helps the patient, again including the patient in all this process through their mobile app. We created these provider dashboards where providers can see kind of how many food referrals they have sent, how many housing referrals they have sent, and what's the situation or what's the status of each of those over a period of time. And then as a result of this, for the first time at a community level, you can really see for different types of social needs, whether food, transportation, housing, money, how many referrals have been made, how many are still open, how many have been completed, and how many have been rejected or left open. And you can then drill down into why these things are happening and how can we intervene to increase the number of referrals that are completed and patients who are helped, and how quickly are we responding to the needs of the patients. So this is an entire system of community social service referrals from clinical setup that allows for a collective action at the community level. So the final thoughts on this is that co-design and co-development of large data integrations in community settings is important, that privacy-preserving record linkage tools that allow for secure linking of data sets while protecting individual health information is possible and should be implemented in order to ensure confidentiality and privacy. User-centered design, and then development, agile development environments where we are reiterating and understanding what patients need, what providers need, what service providers need, can help in adoption and acceptance in the long run. Workflow integration is very important because we don't want people to change their method of doing things there. We want them to be facilitated with technology, and we need more work and understanding to address the integration of social services and healthcare data in communities, because healthcare and social services are both very local in nature, and one size does not fit all. But by building platforms that can then be adopted by communities who don't have to necessarily start from scratch is an important aspect, and that is what we have partnered with the Department of Health and Human Services at the federal level to build as a platform which we hope will be able to be scaled to other communities. We have already seen some of that scaling in a few states within the United States, but we also hope that some of you globally would also be interested in testing these things. So based on that, these are some of our partners, and we want to thank our partners who helped in doing this work. A lot of it was funded by the Office of the National Coordinator for Health Information Technology and Michael Susan Dell Foundation, which is a private foundation. And we had a team of people who worked on this, so we want to be grateful for them. Here's my contact information. Any of you wanted more information about this platform and how to implement this in your communities, please feel free to contact. And with that, I will stop here, and again, thank you for the organizers to giving us the opportunity to share our work with you, and I look forward to being in person with some of you and interacting with you virtually in the future. Thank you so much.